Hi, this is Andrew Merritt, and today we're going to talk about knee arthritis, one of my favorite topics, as well as one of the most common things that we talk about in orthopedics, especially people that take care of knees. About 700,000 knee replacements are done in the United States every year, so this is a very common topic. A lot of people will be dealing with this as they go through life. It can be from wear and tear, it can be from a previous trauma when you were younger, it can be from lots of different aspects, but knee arthritis, what it is, how we take care of it, and a general overview of the conversation that we have when someone comes in the clinic with knee pain and we've diagnosed arthritis. So let's take a look. First, we got to learn what's normal. Okay, so look, this is looking at a normal knee X-ray. Okay, so what we see when we see a knee X-ray is the bones, which are calcified, so they show up on the X-ray, and then what we're going to be looking for is the joint space. So in the parts of the knee, the inner side, what we call medial, the outer side that we call lateral, and then underneath the kneecap, or patellofemoral is what our term is. Here we can see a normal knee, good joint spaces between this space. All through here is the cartilage. That's what keeps the bones apart. And what you will see, a lot of people have heard that term bone-on-bone arthritis. We'll see, it's just a visual description of what we see on an X-ray. So this is a normal knee X-ray. If we look on an MRI, same thing. What we see is the cartilage holding the bones apart. The bone is the black, the cartilage is the gray in between. So the bone down here, the cartilage between. Now the meniscus comes into play, and I have a whole nother talk about meniscus, everything. That's a whole separate problem, but they are related when you have arthritis, because as these spaces come together, you can imagine that meniscus between gets squeezed. And so most people, pretty much everybody that gets to be severe arthritis, goes through meniscus tears, because there's no way for that place for that meniscus to live when that space squishes down. So this is what a normal MRI looks like. From the side view, you can see that gray cartilage around the outside here. This is healthy, good looking. Underneath the kneecap, the same thing. Actually, the thickest cartilage in our body underneath the kneecap, that's looking from the front of the knee. So here's the front of someone's knee, this is the kneecap, and then underneath what we call the trochlea, it's just the cartilage on the femur part of where the kneecap rides. So this is normal. This is what we want to see, thick, healthy cartilage. Now, as arthritis progresses, it goes through stages. It's not just one day you don't have it, the next day you have it. It's a complex process that starts by breaking down a little bit of cartilage. You start sort of, I think of it like a street, a newly paved street is perfect knee. Then you start getting little potholes or little cracks, then little potholes, then lots of potholes, and eventually all of this sort of degenerates. And so there's stages that we use where we get from, very minimal arthritis, just a little bit of some narrowing, probably not even the problem, just a little wear and tear through life, start getting some fissures, some potholes here at grade 3, a lot of joint space narrowing, and then eventually exposed bone. And really what it looks like is more like this picture on the right side here. It's much more complicated by the end of it than just the cartilage is worn. You get bone spurs. People talk about bone spurs. Well, bone spurs aren't the problem. It's a sign of the problem. We see them and we take care of them when we do a knee replacement. But by this time, we have exposed bone pockets all over. And you can imagine this is why orthopedic surgeons and the research on this of things like an injection of stem cells or something, it's not going to build back the cartilage. It's just, there's too much going on. It doesn't know to rebuild the cartilage. And even if it could, the problem's much more significant than that. The space isn't there. The bone spurs are sticking into the joint. The meniscus is torn. It's a much more complicated physiologic and biologic and mechanical problem than just put a little injection of stem cells or something and your body knows how to regrow that cartilage. So by the time we get to severe arthritis, we're really looking at a pretty complicated problem here. So as we go through that step, we can see each of these steps on X-ray. So here's mild arthritis and moderate arthritis. And what we're looking at, I did examples of mainly on this inner compartment, what we call medial again. We see a little bit of narrowing, a little bit more narrowing. Now this is where we can start to get those meniscus tears, because if we were to draw in the meniscus here, that little wedge that we looked at on that MRI, you can see that starts to squeeze that meniscus there. And so this is when we start having meniscus tears. We talk about, well, is the pain coming from the arthritis? Is the pain coming from the meniscus tears? What do we do about that? But that's moderate arthritis. And then we start to talk about the severe arthritis. This is where we get that visual description of bone on bone. You can see why we call it that. It looks like the bone's on the bone. This is complete absence of cartilage. The meniscus has surely torn out of the way. To get out of the way, we even see some bone spurs out on the side here. This is the point when we start talking about as an option would be knee replacement surgery. And most of this talk will be talking about knee replacement surgery, what we do about this. Now, people can continue to do well even at this level of arthritis. There's lots of people out there that are still quite active because their body has had a chance to toughen up a little bit, kind of get used to this problem. And there's people that are still very active on that level of arthritis. So we see people that come in not till it's at this stage, which just huge bone spurs over here, absolutely no space. They've started to erode the bone away. This is getting to be more and more significant arthritis. So up into the point of needing surgery, there's lots of things that can be done. First of all, I encourage people to stay active. Now, the way they stay active might need to change from impact activities like running to more like using the elliptical, or starting to do pool therapy, starting to do more walks instead of impact. But staying flexible, staying fit, keeping good muscle strength, these are all the things that really help people continue to do well with their arthritis. Two people with the same level of arthritis can be doing very different as far as how they feel living through life based on their body weight, their strength, their flexibility. Generally, people start taking things like anti-inflammatories, Aleve, there's Advil, ones that we prescribe. People have taken turmeric and fish oil, all working as mild anti-inflammatories. Supplements can be done, glucosamine, chondroitin, all of these. And there's no perfect science on all of these. Most of them probably work just as a little bit of take the edge off anti-inflammatory, but there's pretty low downside, at least to the fish oil, turmeric, and the supplements. The anti-inflammatories for a long period of time, there's some issues that come up, and you need to talk to your primary care doctor about taking those long-term. But for short-term use, those are fine to take the edge off. People, when they start seeing us, then we start talking about injections. Cortisone is an anti-inflammatory. It's essentially like, it's a steroid that's like taking a big bottle of Advil and just injecting it into the knee joint. That can work to decrease the pain and inflammation. Hyaluronic acid, or what people call the gel injections. Again, we can talk about these if you come into clinic, but this is a mainstay of sort of working through the process as we go from mild arthritis to more severe arthritis and eventually needing surgery. PRP can be done. That's where they take your blood and spin it down to the healthy healing portions of the blood and inject into the knee. Still really working as an anti-inflammatory, not rebuilding cartilage. Anyone that wants to sell you stem cells and says they can rebuild the cartilage, have them show you the data that shows that, because there's no papers out there that show that you can rebuild cartilage. The process is just too complicated. It's a lot more going on than just the cartilage is thinning and you can inject something to build that back. It's a mechanical problem, and you can see that from those previous x-rays that there's bone spurs, there's all sorts of degeneration, the joint space is gone, you would have to build back that space. So stem cells are not really shown to be a benefit in this, although there's plenty of anecdotal stories of people being helped by that. But if you look at large populations, not great data on that. And then some bracing options. I'll show you briefly an unloader brace. For physically active people, there's ways that we can actually help their unload the compartment that has the arthritis. So here's an x-ray on the left of someone that has arthritis, right? They're starting to touch bone, but the outer side of their knee still looks good. This brace creates a 3-point fulcrum, actually opens up this knee joint. So this inner side opens up. So here's an x-ray of this person now standing with, you can see the brace on, and see how that opens up that space. Again, we're not changing the problem that they have arthritis. What we're trying to do is unload, relieve the area that's symptomatic so that they can continue to be active. Again, delaying surgery until it's really necessary. This is one of the options. Unloader braces in active people, especially if they have thin legs, so the brace fits nicely, can be pretty effective. So there's lots of steps for, even though we do 700,000 knee replacements in the United States a year, there's even way more people than that are in the process of sort of progressing through it and getting treated with this conservative management. So this is all things that we talk about in clinic when someone's going through this process. Eventually, knee replacement does become an option, and there are different options even with knee replacement. I would say of all the things that I talk to with people, the most confusing of what actually happens when we do a knee replacement is knee replacement, is what is actually happening at surgery. So I want to explain that and demystify that a little bit. So there are partial knee replacements and full, and all full means, so full or total knee replacement here on the right means that we replace the inside, the outside, and underneath the kneecap. So the three compartments of the knee. A partial knee is where we would just replace the inner side here. Leave the outside, leave underneath the kneecap. Or in the case of a patellofemoral arthroplasty, leave the inside, leave the outside, and just replace underneath the kneecap. So there are lots of options. And this comes down to my concept and my practice of joint preservation. Keep as much of your normal anatomy in your knee for as long as it's appropriate for that problem. So even when we do a total knee arthroplasty, we're not actually replacing the knee. The term is a little bit wrong. A total knee arthroplasty, again, just means the three compartments. What we're replacing is the degenerative cartilage and the meniscus. So what's removed is only about 8 or 9 millimeters of bone, so less than a centimeter of bone on each side of the knee. The menisci, generally because they're torn up anyway, we get those out of there, and the ACL because it's in the way of the implant that we put in. All of this stuff remains. So the vast majority of your knee still remains in there. So if we look at a knee replacement model, here we have a model of a knee replacement. Now it's a little confusing because the clear is actually representing your own bone. So there's clear on the femur here, on the tibia here, and the bands on the side represent your ligaments. So what's actually being replaced is just the cap on the end of the knee. So this is only about 9 millimeters thick of metal that we make these special cuts on the end of the femur to fit this implant in there. We do the same thing on the top of the tibia. So it's a little hard to see on this clear model, but the concept is we're really just kind of capping or resurfacing the ends of the bone. Yes, we use metal and plastic to do it, so it's not putting cartilage back into the knee joint, but it's doing so with metal, but only about 9 millimeters on each side. So during that surgery, at the end, when we're ready to put in the implants, the gap between is only about 18 millimeters, 20 millimeters of space to put this implant in. So it's not like we cut at the bottom of the knee, cut at the top of the knee, and put in some big fake knee. And we can see that on the x-ray. So here's an x-ray after we've done a knee replacement. So I like looking at the right side first here, and you can see we're just capping the end of the bone. So this is all normal bone. This is where your MCL and your LCL on the other side attach. Yes, there's these little spikes down into the knee. That's just to get good fixation. But the only part that's been removed is this 9 or so millimeters and this 9 millimeters to fit that implant in. So most of your knee still remains. From the front, you can see it does look a little bigger, but that's because you're looking at it head on versus the side. So since the x-ray doesn't go through the metal, it shows up really bright there. But again, this is the only space that's removed in the knee joint. Here's the fibula, the MCL on the inner side, the LCL on the outer side, the quads, the patellar tendon. All of this remains in the knee after a knee replacement, even a total knee replacement, because again, total just means the inner side, outer side, and underneath the kneecap. One of the fun things, so this is where my job and why my background as an engineer and why I like angles and everything is really fun, is that no two knees are the same. So what we try to do in a knee replacement is restore someone's pre-arthritic alignment. So that means the arthritis or the alignment of their knee before they got arthritis. Because some people, here on this x-ray, you can see some people have a very different angle. This is just sort of very simple of what we start to talk about is even just how the joint line is in the knee is very different amongst people. We start and actually measure these degrees: 82 degrees, 85 degrees, 90 degrees. So there's a lot of alignment issues that we take into account, because some people, you can see this if you're at the supermarket and you watch people walk, is some people have very straight legs. Some people, they're bent to the outside. Some people are bent to the inside. Some people have very different rotation of their knee. And so this is what we're trying to match when we do the surgery. So here's an example of that. This person is what we call varus, or 83 degrees. So this would be a bow-legged type of person. Well, we want to put that back. And here you see we can match that with this implant from what they had before. If you try to make this person straight, they're not going to be happy. It's going to overstretch the inner side of their knee if you try to crank them too far over. So this is the fun. This is the art of the surgery. This is essentially the skill that's involved of trying to match the person's anatomy. One way that we do that sometimes is with robotic assistance, and you've heard of now getting into the operating room with robotics and robotic tracking and all this planning that we do before surgery. So one of the ways that we do that is with robotic total knee arthroplasty. And I'm still at the point where I think this is good for some patients, but not all patients, because of technical reasons that we can always discuss. But essentially what we do is we use sensors on the knee and a saw that has sensors that are tracked. And this is kind of like how they make movies with CGI, and they're very accurate motion capture. And we can live move the knee and check how the stability is in the knee through the entire arc of motion. Now, the implant that's put in is still the same, but this is how we make the cuts to better match the patient's native alignment. This is one of the fun things that's coming out with surgery. And so we can be very precise down to the 0.5 millimeter of how we make these cuts, and 0.5 degrees of all the angles you can see. This is the planning screen that we use for the system. And on the right side is tracking actually how this knee is moving and the spaces as it goes through the motion. And we can adjust all of these factors on the left to get that graph to balance exactly like we want. So that's kind of one of the fun stages of surgery at this point. The other thing that I'm very big on, again, is keeping as much of your native knee as possible. So I do a lot of partial knee alignment or partial knee arthroplasty. This is when we only replace a part of the knee. A lot of people, either from trauma, previous meniscus tears, a lot of people only have arthritis in one portion of their knee. So for example, this patient, only arthritis on this inner side. Perfect ACL, perfect lateral, outer compartment, lateral compartment, perfect underneath the kneecap. Why go and do a total knee replacement? All you're doing is replacing 2/3 of the knee that is completely normal just to fix the one part that's not. So what you do is you do a partial knee replacement. So a partial knee replacement model would look like this. Again, clear model, so it's a little bit hard, but you can see that the implant is just on this inner side. So the metal that's replaced only affects the inner side of the knee and not the outer side of the knee joint. Otherwise, the ligaments still stay in place. In this one, the ACL does stay in place, which is removed in a total knee, and it's really the only other difference besides leaving all the rest of the normal knee there. You can see that on a side view here of after a partial knee replacement, how we just do the inner side of the knee, and again, just resurfacing where the cartilage was lost. Now, what's the recovery like after a knee replacement? Yes, it can be a painful surgery. We work really hard at surgery. We do special blocks. We do special numbing injections. We try to do minimally invasive surgery when the anatomy allows. We try to do a partial knee replacement. All of this is not only for better function, but also to improve the early postoperative recovery. So I like this graph that was made and shared online, which is sort of the stages of going through a knee replacement recovery. First couple days, usually not that bad because we have those blocks. Those are all working. The pain's not so bad. So not as bad as expected. And then we get some swelling, and then why did I do this? That's sort of the first couple of weeks there. And that's because now you're swollen, you're in physical therapy, we're making you move the knee, and yet you don't want to because it's sore, it's painful. And then over time, we continue to improve, but it's a little up and down. What we see is most of the time people are better than before surgery around the 6-week mark, and then you start to reintroduce activities. So the first day you go back to golf or pickleball or using it a little more, well, it's going to swell, it's going to be a little irritated. So a lot of times it's 2 steps forward, 1 step back a little bit. But the goal is to continue up and to the right. Most people very happy with the surgery. Some a little mixed, and fortunately it's pretty low. If you select the patients correctly, which we're pretty selective about offering the surgery for people, very rare, and I would say it's less than 5%, but that's what's out there, that the knee replacement, they're not happy that they did it. But people continue to get better for a full year after this surgery. So just as an overview, so joint preservation, we try to save as much as the knee as possible. When someone comes in with a meniscus tear but no arthritis, we'll fix that meniscus. When they have an ACL tear, we'll fix the ACL to stabilize the knee and prevent arthritis. So a lot of this is about prevention. Once we start getting arthritis, conservative treatment, continue to be active, continue to work on strengthening, flexibility, use injections, physical therapy, bracing to maintain an active lifestyle. Eventually surgery, try to do minimal surgery, try to do a partial knee if you can, total knee if the arthritis is around the joint more. Respect your native anatomy, try to get the alignment perfect to where you were. These are all the things that contribute to having 85% success rate. And then rehab, working really hard with physical therapy. That's where your job comes in after the surgery, to get back that motion, get back that strength. Fast forward a little bit, I'm going to show one picture that does show an open knee at the time of surgery, just to show you. So graphic photo coming up, 3, 2, 1. So this is a knee arthritis picture. So here's at the time of surgery. This is all exposed bone. So see how it looks a little different. This on the outside still has some cartilage here, but the arthritis extends all the way up. This is the trochlear part underneath the kneecap. And you can see how the color is different on this inner side here versus the outer side. Cartilage is more white, more this peach color on the inner side is the arthritis. And they've even started eroding this bone. Here's a big bone spur in the front. So this is a full knee replacement. And after a full knee replacement, you can see again how much we leave of the normal knee and then the metal implant on the end. The plastic spacer here, and then the metal implant down below. And this is now what you're walking on. And these implants grow into the bone. They're not, and most of the time, needed to be cemented anymore into the knee joint. So this is the overview of arthroplasty of the knee. This is one of the most common things that we take care of. And there's a lot that can be done before surgery, a lot of important things that we take into consideration during surgery, newer advanced techniques, including robotic, partial knee, all of the things to help restore normal anatomy, normal function of the knee as best as possible. So thank you for watching, and I hope that you learned some about total knee arthroplasty and generally how we take care of this as an orthopedic surgeon. Please give us a call if you have any questions or would like to be seen for this problem. Thanks for watching.